Nice. Welcome, everybody. My name is Marty Mascari. I'm with the North Central Texas Area Agency on Aging and the Aging and Disability Resource Center, both of which are under the umbrella of the North Central Texas Council of Governments. We are once again very, very blessed to have James Out West Center partners with us today, Jamie Cobb Tensley and Hollie Glover, who we're going to talk about the topic that's on your screen right now, but I'm not going to try to go through it and pronounce it all. I'll just bust. It's traumatic brain injury, chronic traumatic encephalopathy, normal pressure
hydrocephalus.
Hydrocephalus. I'm sorry. Let's just move on. Let's just move on to CEUs. And just so you know, I will not qualify for CEUs today because I could not get through the title. Sorry. Jamie, do you want to go ahead and tell us about CEUs?
Yes, thank you. And it is a mouthful for sure. But we are happy to offer CE credits for nursing, social work, licensed professional counselors in the state of Texas, and anybody needing a certificate of attendance for the program. You must attend the live program to get the CE credit, and you must complete the SurveyMonkey evaluation that will be in a follow-up email from Marty later on today or tomorrow. That link we ask everybody to complete the evaluation, but you must complete that by the cutoff date, which is the end of the day, September 21st. And then we can process those CE certificates and get those back to you. If you'll please allow us about 3 weeks after the 21st, so 4 weeks from today, to get those back, the certificates to you through your email. We would appreciate that. And that's what I have. Thanks, Marty.
Very good. Thank you so much. In addition to the SurveyMonkey, and please note that the SurveyMonkey is what is required for the CEU certificates and for your certificates of attendance. We're also going to have a Google survey that we ask for you to complete for our reporting purposes for our grant money as we report on the goals and objectives that we set forth in applying for our funding. So if you complete that as well, that should pop up when you close out of Zoom today. And if it doesn't, that will also be included in the follow-up email. I know that email will not go out until tomorrow because I have a commitment right after this. And so you should look for that to go out tomorrow. So now I'm going to turn it over to Hollie Glover and let her talk to us about the topic that's on the screen right now.
Thanks, Marty. It is a mouthful, that is for sure. So we have been doing a series of programs over the last couple of months, and we'll continue to, of other diseases, issues that fall under the dementia umbrella that many times people don't realize they fall under that dementia umbrella. We have got a couple of slides here about the West Center. So if you have any further questions about the West Center, you can contact one of us. We are a long-term care center in Fort Worth, Texas, and all we do is memory care. We've been here for 29 years. We also have an adult day program, and after the first of the year, fingers crossed, we're going to have a short-term rehab that specializes just in folks that have dementia. So that's our information. There's our objectives for those of you who are going to be getting the CEs later. But let's jump in. Throughout the course of this program, I've got I think 3 little short videos. Most of them are about 3 minutes. In fact, one of them is just 1 minute. So we can kind of deep dive a little bit further into each of these, just in case they are some terms that maybe you have not heard of before. But let's start with traumatic brain injury, because we do tend to hear more about, you may have just heard them called TBIs, and what they are. So listen to this report from the CDC. Between 2006 and 2014, the number of TBI-related emergency department visits, hospitalizations, and deaths increased by 53%. Those who survive a TBI can face effects that last just a few days or that last the rest of their lives. Effects of a TBI can include impairments related to thinking, memory, movement, sensation, or emotional functioning. So keep in mind, and we're going to watch a short video that's really going to drive home, that not all blows to the head or jolts to the head result in a TBI. We're talking about the repetitive blows or jolts to the head for TBI, and then CTE. It's going to roll on over into CTE, and again, we'll dive right into that. But what do those symptoms look like? And one of the things that's going to be said on the video is that many times after somebody has a blow to the head, they may try to just kind of shake it off like, I'm okay, I'm okay, I'm okay. But we need to know what to be looking for ourselves. Some of the things that happen, if you notice there, that bullet point that says symptoms can appear immediately, or they may not appear for days or even weeks. But we've got to know what those symptoms are. They can be from mild symptoms all the way to severe symptoms. So it might be something that we may be putting off to, oh, that's just because of something else. And it's actually because they had that jolt or blow to the head. It can affect those brain cells temporarily, but it is a change in mental status or consciousness. So if someone is knocked out temporarily, there's also a severe injury, which can result in bruising, torn tissue, bleeding, a long period of unconsciousness, or even memory loss. So this picture does a great job at showing a concussion. What happens with a concussion when we have that? This is showing like a blow to the head in the front. That brain, and if you can imagine, our brain is about 3 pounds. A normal brain is about 3 pounds. And about the if we were trying to hold some Jello here, and it rotates and it bounces around inside that skull that's there to protect it and can be damaged. We're going to start with our first video. This one is the one that is under 2 minutes, where he's going to talk about some misconceptions of TBI.
So are there in fact misconceptions in the public about traumatic brain injury? I think there are a few, and they do need to be addressed. Number one is having a traumatic brain injury is not necessarily a lifelong, irreversible, debilitating event. You can recover from traumatic brain injury. And in fact, mild traumatic brain injury, it's expected that you will recover fully from it. So that's number one. Second is that traumatic brain injury, concussion, are two different things. They are not. They're the same thing. A concussion is a mild traumatic brain injury. That's exactly what it is. And because of that, you have to recognize that it is in fact an injury, and it does need to be taken seriously, much like a sprained ankle does or fracture. This is a fracture of the brain. This is a sprain of the brain. So a severe traumatic brain injury can be thought of a fracture of the brain. A concussion can be thought of as a sprain of the brain. And we all know that you recover nicely from a sprain if you treat it properly. So a mild concussion should not be ignored. It should be seen by a medical professional, and there should be a care plan instituted, and most certainly take them away from a risk of having a second injury. So assuming that a concussion and a mild traumatic brain injury are not the same thing is a misconception, and a very important misconception. And finally, I would say is that the long-term consequences of a mild traumatic brain injury is not scary. It actually is a very recoverable event. And so because of that, patients who get this injury need to be cognizant that there is every expectation that they will recover. So because of that, they should not try to hide it. They should not try to, in fact, reduce its importance. They really need to take and treat it seriously, because if they do so, they will have a very good outcome. And the last thing is we all should recognize that the injured patient may not know that they're injured. I think that's very, very important. So if, in fact, we are playing sports with somebody and we see that they get hurt, and they get up and they dust themselves off and they say, no, I'm fine, they may not be fine. And it becomes our obligation to sit them down and say, no, sit down, let me take a look at you. Because they may not know they're hurt. And it's really then becomes incumbent upon we, as their friends, as their family who care about them, to do the right thing. So in this case, parents and colleagues have to be proactive on this condition.
I thought that was perfect for us to understand whenever he talked about comparing it to a sprain and a fracture, because we get that. We understand the difference in a sprain and a fracture, and that it's that serious that a person may think, I'm okay, I'm okay, I'm okay. But anytime it is something to do with the brain. So let's look at those symptoms. And again, Marty has put in the chat these slides. You will get a copy of them, so you don't have to be trying to write all of this down. There are so many different symptoms. This is the first page of symptoms. This is the physical and sensory symptoms that someone might have. And like he said, sometimes it's us, maybe it's our loved one who falls or hits their head, and we're not sure exactly what to look for. But here are some of those things to look for. And it's divided into mild and severe. So it really gives you a good look there. Physical and sensory symptoms, some of the ones that might stand out. On mild, the ringing in the ears or the blurred vision, problems with speech, and then go over to severe. Any mild symptoms that persist or worsen, convulsions or seizures, a dilation of the pupils, weakness and numbness in fingers and toes. So these are some of the physical symptoms. Let's look then at cognitive or behavioral symptoms that we might see in somebody with a traumatic brain injury. And you heard him say in the video, there is mild traumatic brain injuries, and then there are severe traumatic brain injuries. So on the mild, loss of consciousness for a few seconds up to a few minutes. Maybe even they didn't lose consciousness, but it's like they're dazed, they're confused, they're disoriented. Sleeping more than usual. Over on the severe side, not being able to recognize people or places, slurred speech, all the way to coma. So what are some of the risk factors and what are some of the causes of TBI? Some of you may already be thinking ahead of where do we usually see these TBIs, these traumatic brain injuries. Let's look at the causes here. Now, I want you to notice this very first sentence because this is important and this is how it then relates to dementia. Over the past 30 years, research has linked moderate and severe TBIs to an increased risk of developing Alzheimer's disease or another dementia years after the original head injury. And then repeated TBIs, we're going to roll right into the next one on the next slide, is what's associated with chronic traumatic encephalopathy or CTEs. Again, that second paragraph. According to the Alzheimer's Association, studies have shown that people who experience TBI in early to midlife are 2 to 4 times more at risk of developing dementia in late life. Hear that sentence. That is important because many times people will say, oh, but that happened years ago. That's when they were in high school. That's when they were in college. Look at that sentence. Alzheimer's Association studies have shown that people who experience TBI in early to midlife are 2 to 4 times more at risk for developing dementia in late life. I know where some of your minds are going right now. Sports injuries. And you're exactly right. So look there on the left at the causes. It could be a fall. Maybe somebody falls off of a ladder. Maybe they fall and they hit their head on a piece of furniture, a vehicle accident, a collision, a wreck, domestic abuse or violence, sports injuries, and then with our military, explosive blast or combat related injuries. We see this over and over and over again. Here's some more risk factors. Children between the ages of 0 and 4, you see more falls. Young adults between 15 and 24, first is sports, then car accidents, violence. Then when you go to adults ages 60 and older, falls is number one, and then car accidents. And then men are at a higher risk than women. And look at what is first: sports, car accidents, combats, and falling off of objects, because, no offense, guys, we do know that men do tend to exhibit more risky behavior, and will take chances that you might not see a woman taking. I've got a picture of this as a man is laying across a mattress and it's going down the interstate at 80 miles an hour, and he's laying on the mattress in the back of the truck. Don't do that. Okay, that goes right into chronic traumatic encephalopathy. It's got a complex relationship to head traumas as a post-concussion syndrome and a second impact syndrome that occur earlier in life. So there's lots of information on this slide. It's a pretty rare disorder. It is not completely understood. There's still a lot of research going into CTE. But what I said earlier about the early to midlife brain injury, that second bullet point, CTE is not related to the immediate consequences of a late life episode of head trauma. CTE is coming about because of the head trauma that we received earlier in our life. So who is that we're talking about? Football players, other contact sports, people who do boxing, military personnel is where we tend to see CTE again and again. You've probably heard about this on the news. People are starting to talk about it more and more. CTE cannot be made as a diagnosis during life except in those rare individuals with high risk exposures. Researchers do not yet know the frequency of CTE in the population and do not fully understand the causes, and there is no cure. I've got about a 2-minute video that's going to answer a few more questions about this. Very simple video.
Chronic traumatic encephalopathy, or CTE, is a neurological condition linked primarily to repetitive head trauma. Most cases of CTE occur in those who play sports where head injuries are common, but anyone who has experienced repeated head trauma is at risk. CTE symptoms generally begin to appear years after head trauma and may include memory deficits and other cognitive impairment, abnormal behavior such as paranoia, aggression, and impulsivity, mood disturbances such as depression, and movement problems such as tremor and other symptoms similar to those seen in Parkinson's disease. In most cases, CTE is a progressive condition that gets worse over time. Although the pathology of CTE in the brain is not fully understood, a common feature of CTE involves a protein called tau that's normally involved in maintaining the structure of the cell. In CTE, tau proteins accumulate in neurons and other cells like astrocytes to form abnormal clusters or aggregates. The tau aggregates are called neurofibrillary tangles when they form in neurons, and astrocytic or glial tangles when they form in astrocytes. The role of tau aggregates in disease progression is still not fully understood, but it's thought they can disrupt cellular communication, and their presence is associated with the degeneration and death of neurons. They also seem to be able to spread throughout the brain, so a neuron that develops neurofibrillary tangles may cause surrounding neurons to develop them as well. Initially, tau aggregates primarily form close to the surface of the cerebral cortex, but as the disease progresses, they spread throughout the cortex and to other areas of the brain like the hippocampus, amygdala, and various other regions. The spread of the tau pathology is correlated with other degenerative signs, such as general atrophy of the brain, severe neuronal loss in areas such as the hippocampus and amygdala, and less substantial neuronal loss in a number of other brain regions.
A couple of things I want to point out from that video that he said. You notice that he said this shows up years later. It's repeated TBIs, traumatic brain injuries. So we see it more in people who, again, were in the military, played a sport where they took a lot of blows to the head. So football, boxing, even something like a rodeo, anytime where somebody is hitting their head. You'll even see this in gymnasts, as I was reading more about it, where they don't wear anything to protect their head. And over the course of a career, they'll have multiple falls or multiple concussions. Another thing you may have heard him mention was the word tau protein. So you may recall when we talked about, we've done programs about Alzheimer's disease. We talk about the tau protein that shows up. You also heard him mention that they may have a paranoia or a tremor that's similar to Parkinson's. What's interesting, though, as you start to study the diseases of the brain, is that a person can have a CTE and have Parkinson's. They can have Alzheimer's and have CTE. They can have a dual or a mixed diagnosis of any of these, of any of those over 130 different conditions that falls under the dementia umbrella. These are just a handful of them. So we wanted to put this slide in here as well, because this is what CTE actually used to be called. So you may have heard this term before, and I attempted to pronounce it earlier and really messed it up. So we're just going to leave the slide up there. But this is describing, and this again talks about wrestlers and boxers. And we've got a fire alarm going off, so we'll just continue on, just ignore what you're hearing there. But it's a variant of chronic traumatic encephalopathy. It's also called chronic boxer's encephalopathy. You may remember that Muhammad Ali had Parkinson's, but Muhammad Ali had CTE. Muhammad Ali had TBIs. And look at what this says. The average time of onset is between 12 and 16 years after the start of a boxing career. Now, here's some of the symptoms of this. If you'll look at the picture on the page, look at the control on the left, there's CTE in the middle, and that's Alzheimer's disease on the right in this picture of the brain. Symptoms can occur with many other conditions, like we said before, but they can show up as, well, when somebody presents with some of these things that you see there, depression or apathy or emotional instability, the last thing they may be thinking of, they may not even, the doctor might not even be putting the puzzle pieces together that this is CTE. Suicidal thoughts or behaviors is on there, substance abuse. How do we get the diagnosis then? There's no official test to diagnose. That's why in the video, they had mentioned that CTE until autopsy, that they don't know for sure until autopsy. But they can usually, when they get a really good background, and if they have got, they can tell that they have had the traumatic brain injuries, especially if somebody has kept a good medical history, then they can figure out that that's what this is. Somebody who's had a repeated head trauma. Okay, the alarm has stopped. There's no medications to treat CTE. All we can do is symptom management, which is with most all of the dementias. There are no memory meds. All we have are medications that treat individual symptoms. Let's go to our next one. You may have heard of this one, normal pressure hydrocephalus, or sometimes it's just called NPH, normal pressure hydrocephalus. So what is going on with this one? Now, this is one of the rare diseases that falls under that dementia umbrella that can sometimes be reversed, that a person might get better. For the most part, anything that falls under the dementia umbrella, we're not reversing it. It's progressive and it's terminal. But let's look a little closer at normal pressure hydrocephalus. What is it that's going on? It's an abnormal buildup of the fluid in the brain's ventricles and the cavities. And that causes those ventricles to enlarge. It puts pressure on the brain, and it can disrupt and damage brain tissue and cause numerous impairments in brain function. We're actually going to look at an MRI in just a minute of a brain that has normal pressure hydrocephalus. It can occur at any age, but most commonly we see it in people that are elderly. And of all the dementias, and again, there's over 130 different types of dementia, it accounts for about 5% of the dementias. So what causes it? It could be a ruptured aneurysm. It could also be from a head trauma. It can be from an infection like meningitis. It could be from a tumor, complications after a surgery, and then, of course, the unknown cases. Here's what it looks like. Wow. Look at the difference in that normal brain on the left and the brain with the normal pressure hydrocephalus on the right. And again, we're going to watch less than 2 minutes to explain this condition a little better.
Normal pressure hydrocephalus is a brain disorder where there is buildup of fluid inside the brain that can lead to different types of symptoms. People can present with walking disturbances, problems with memory and thinking, and problems with bladder functions. These symptoms of normal pressure hydrocephalus can often look like other degenerative disorders like Alzheimer's disease or Parkinson's disease. At Yukon Health, we've built a multidisciplinary team where we bring in experts from different disciplines. We diagnose a patient primarily based on clinical presentation, but we use different non-invasive modalities like imaging, urinary testing, and neuropsychological testing to aid in the diagnosis and appropriately select the patients for further evaluation. Diagnosing and treating it early does lead to improvement in symptoms and prevention of progression of the disorder.
That's the key right there. Diagnosing early to lead to help with the progression of the disorder. Now, you heard her say how some people will come in and present where they look like they have what appears to be Parkinson's, again, that one comes up, or Alzheimer's disease. She also mentioned that they may come in because they are having bladder issues. And so you heard her talk, there's a full battery of tests. This is not something that a person is just going to go to the doctor the one time and they're going to get this diagnosed. She said they go on their clinical presentation and that they do need to do that full battery of neuro tests. So let's look at what is happening with the normal pressure hydrocephalus. It is a progressive decline. And so that is why she was saying we want to get this one early, because this is the one if we can catch it early enough. And then there's that about the bladder, impaired or loss of bladder control, urinary urgency, or even incontinence. Starting to have that poor balance or gait. They may feel like they can't pick their feet up, or they may develop that shuffle that we see in so many of the dementias. We even call it kind of a dementia shuffle, where they're not fully picking their feet up off the floor. They may even have their hands out to the side because they may feel like they are about to fall. Other symptoms, and then you see there where again, it's saying it can look like Alzheimer's or Parkinson's. And so many times this will go misdiagnosed, and it takes a long time for them to get it properly diagnosed. And you see that last bullet point there, again, from the Alzheimer's Association, less than 20% of people with this disease are properly diagnosed. So here's the diagnosis and the treatment. They use a variety of tests, and they're going to do an MRI, or they may do that CAT scan. They're going to do a spinal tap, a lumbar catheter to check for pressure. Then they want to do the neuropsych test. That neuropsych test is also going to help them rule out other conditions. The symptoms will get worse over time, and it will become fatal if it is not treated. Again, early diagnosis and treatment improve changes of partial and complete recovery. This is one of the few that can be reversed. And it's one of the few that we have some control over. We talk an awful lot about vascular dementia, probably the one that we have a little bit more control over. Most common cause of that is strokes from being a smoker, uncontrolled high blood pressure, uncontrolled cholesterol, diabetes, something along those lines. So there's just a very few that we have very much control over. So what is it that they can do? They can actually go in, making sure everything's okay. It appears to be. They could actually go in and put in a surgical shunt to drain off that excess fluid, and they drain it into the abdomen where it is then absorbed as a normal part of the circulatory process. This process allows the brain ventricles to return to their normal size. However, it does carry a risk. The procedure carries risk. Regular follow-up and care with a physician is important to identify subtle changes that might indicate that there is a problem. And right down there at the bottom, you'll notice where it says success of treatment varies from person to person. Some trials suggest improvement of symptoms range between 50 to 90% of persons having the shunt. And not everyone who improves will sustain or maintain over the long term, but there is hope. The main thing with this one is making sure to get diagnosed early.
Holly?
Yes.
I'm going to take a 2-minute break, and I want you to go see what's going on. We can take a 2-minute break, and you can go ahead, and we're going to take a 2-minute break, y'all. And Hollie's
Well, I figure that Jamie will come and tell me if we're actually on fire. I don't think we are.
Yeah, but if it keeps going, I know, but I'd rather you know and not think.
Okay, let me mute this real quick. I will be right back.
Yeah. You guys, we're going to hang on for 2 minutes, and she'll be right back. Let's make sure there's not a fire in the house. Thank you all for your patience. All of you should have gotten the link to the slides that we download, or that you can download of the slides for today. I've put that in the chat a couple of times. I'll put that in the chat again. For those of you that might be new, you should be able to find those links in the emails that come to you with the login information. I know the early one didn't have it. I didn't have them yet, but in the one that came out today, an hour before, if you look towards the bottom of those emails, you should see the links for those flyers. I mean, for the slides. I usually try to get them out before the webinars if we can, but I've also put that in the chat. I'll put it in the chat again here in just a second, just to make sure you all have that. Thanks y'all for your patience. I'm sure she'll be back here shortly. While we're waiting, does anybody have any questions about us and the webinars we do?
And we're back.
Okay, we're back. I'm going to turn it back over to you then.
It's
Thanks.
all good. It's all
Okay,
good.
great.
These
Thank you
kinds
so much.
of things happen.
And they do, and I just want to make sure that just so you know. Yeah,
Thank you, Marty.
thank
I
you.
did see people starting to gather outside my window, so I thought, have they forgot I'm here? And everybody's left. No, everything's okay. Everything's all right. All right. Thank you so much. Thank you. Thank you. Boy, isn't that life? Hadn't had that happen. I've had it go off before, but I hadn't had it keep going off. So it may go off again. I know my light's still flashing. I'm not at the disco. I know it may look like I got a strobe light. Speaking of strobe lights and seizures or epilepsy, if somebody is prone to seizures, you don't want to be around a flashing light like I have over my head right now. So we're going to go right into seizures and epilepsy. So many times, and again, these next few slides is going to really describe seizures versus epilepsy. There are many different types of epilepsy. Epilepsy actually can kind of be its own umbrella. And because of its effect on the brain can be different for each person, so each experience is unique. Now, let's talk about the difference though. Seizures. There's different types of seizures as well. They are individual occurrences and there are different causes for seizures, and we're going to break that down. What's going on though is there's an irregular activity of the nerves in the brain, and that sometimes causes irregularities that can become recurrent or even chronic. When seizures become chronic or consistent, they then become what's called epilepsy. So 2 or more seizures may be diagnosed as epilepsy. You can have a seizure without having epilepsy, but you can't have epilepsy without having seizures. That makes sense. And I've got, again, a very short video where he's going to describe it even a little bit better. And again, this is about 2 minutes.
It happens when there's an overproduction of electrical activity in the brain.
Seizures can occur for many different reasons, sometimes from metabolic problems, or even medications could cause a seizure on an isolated basis, or sometimes toxic sort of chemicals could cause a seizure.
But if a patient has a seizure, it doesn't mean they have epilepsy.
Epilepsy actually is defined as having multiple unprovoked seizures.
There are many different types of seizures, just like there are many different types of epilepsy. To determine the difference and the cause, patients may undergo a series of testing, including an MRI and an EEG screening.
The EEG is particularly helpful to look to see electrically where in the brain the seizure could be coming from.
A physical examination, a detailed medical history, and diagnostic testing can help physicians diagnose and treat the problem.
They are treated differently. Commonly, if we find there is a provoking occurrence, simply removing the provoking occurrence is enough to cause the seizures to go away. Or if we need to use a medication, if it truly is an epilepsy syndrome.
Approximately 3.5 million people in the U.S. have epilepsy, whereas studies show 1 in 10 people may experience a seizure in their lifetime.
Folks who do have epilepsy, true epilepsy syndromes, the risks of recurrence of seizure can be quite high. So most all of those patients do require medical care and medication to try to control their seizures.
Surgery may also be an option for patients. If a person experiences a seizure, it's important they seek medical care to determine the cause. For Lee Health, I'm Lindsay Morton.
So a couple of the things I hope that you took from that you heard him say was when somebody has multiple unprovoked seizures, that is when they'll get that diagnosis of epilepsy. Multiple unprovoked seizures. And I said they try to figure out, is there a provoking occurrence? Is there something that's making this happen? That of course you withdraw that provoking occurrence. And then he said that 1 in 10 of us will have a seizure at some point during our life. And on the next slide, we're going to look at common causes of non-epileptic seizures. So different type of epilepsy, again, he said that abnormal surge of electrical activity between the brain cells, and it causes that temporary abnormality in muscle tones or in movements, which can result in stiffness, twitching, or limpness, behavior, sensations, or states of awareness. And all seizures are not alike. Let's look at this slide where we talk about causes of a non-epileptic seizure. And some of these, once you look at the list, you may go, that makes sense. Okay, that makes perfect sense. Somebody who's got a very, very high fever might have a seizure. After a concussion, a seizure. Infections, someone who's choking where there's a limited supply of oxygen getting to the brain. Somebody who is withdrawing off of drugs or alcohol may have seizures. Very, very high blood pressure, kidney or liver failure, somebody who's having a hypoglycemic episode where that is going low, and then a stroke or a brain tumor. So the different types of epilepsy, there's generalized where you see it's kind of all over the brain there. These seizures affect both sides of the brain at the same time. Depending on the type of generalized seizure experience, a person may have motor or muscle related or non-motor symptoms. Then let's look at the one on the right. This is called a focal epilepsy, or partial even. These seizures affect only one side of the brain, and depending on the type of partial seizure experienced, a person may be aware of their surroundings or their awareness may be impaired. So they may or may not know exactly what's happening. Some changes in the brain activity during a seizure can affect a person's level of awareness. So there's the petit mal seizure and a grand mal seizure. So let's look at the one on the left. Awareness is not affected during that petit mal seizure. Again, keep in mind, not all seizures are the same. Some people with the partial seizures have no loss of awareness of their surroundings during a seizure. They may cause loss of focus, they may blink rapidly or stare into space for just a very few seconds, or even have a small twitch of their face. I was a school teacher for 20 years, and throughout the course of those 20 years, I've seen both petit mal and grand mal seizures in students. And I had students who I could tell sometimes when they were having that petit mal seizure, but they weren't necessarily even aware of it. We would be in class and just getting that, like what it just talked about, that loss of focus or kind of almost like a blank stare. And then their eyes might blink real fast and it was over. That was it. The grand mal seizure, on the other hand, the awareness is affected. People who are having the generalized seizures and some people with the partial seizures may lose awareness of their surroundings during a seizure. They may fall to the ground and have strong muscle jerking or contractions, and then have confusion, disorientation, or even be unable to respond for a few seconds up to a few minutes. This graphic gives us a really good idea of the signs and symptoms of a seizure and what is going on in the brain at that time. There's that one I was talking about, just kind of that staring, that blank stare, and then it's gone, it's over. But the uncontrollable jerking movements, strange sensations in the arms and legs, or even emotional, and loss of consciousness or loss of awareness. Here are some other symptoms depending on the type of seizure that they may be having. And there are many things listed here: teeth clenching, biting the tongue, making unusual noises, loss of bladder or bowel control, loss of consciousness again. So these are some of the things that we might see. And again, they're all different. So let's look a little more at epilepsy. And he said the epilepsy, multiple unprovoked seizures. So recurrent seizures with no known underlying cause. We don't know what's making this happen. And there's a list here of these different types of epilepsy. Progressive myoclonic epilepsy, and we've got the definition for each of these here: refractory epilepsy, reflex, photosensitive epilepsy. That is what I was just talking about with the strobe lights, which mine just stopped. So that's a good thing. This is the most common type of reflex epilepsy, and it's triggered by flashing or strobing lights. This type of epilepsy usually begins during childhood and may lessen or disappear in the adult years. That's why sometimes if you are at an amusement park and you're getting ready to get on a ride, it will even say on there that this ride has flashing or strobe lights on it, so that people who know that they have this photosensitive epilepsy would know not to go on that. Let's go to the diagnosing, how to diagnose epilepsy. The first thing they're going to do is start ruling out all other conditions that could cause a seizure. Something like, is this interaction with medications? Or could it be a tumor or a stroke or even diabetes that is not controlled? Or sometimes even in an immune disorder, a person can have a seizure. They're going to do some brain imaging to look for masses. That's where they're looking for tumors, and to look for that accumulation of fluid, so that they're looking for the normal pressure hydrocephalus like we talked about earlier. There's that MRI, taking a complete medical history. And I encourage each of you, if you don't already have your medical history written down, please do it sooner rather than later. As somebody who's just undergone some medical testing, it is hard the older you get to sit there and try to remember every surgery, every hospitalization, everything that you've ever had. Please have a place where you're writing all of that down. Also going over our medication review to make sure that it is not a medication interaction or a medication with alcohol interaction can cause a seizure sometimes. During that neurological exam, testing cranial nerves, complete blood work. And you heard him mention on the video EEG and how important it is to get that EEG because it can pinpoint the location of where the seizures are taking place. And here's some causes of epilepsy. And the number one cause of epilepsy in later life is stroke. Sometimes they are never able to figure out what causes epilepsy, but the number one cause later in life is stroke. But notice there also we've got head trauma, brain tumors, drug and alcohol use and withdrawal, infections, somebody even becoming septic because of an infection could have seizures. And then this bottom one, I wanted to make sure that everybody sees this, sleep deprivation. Sleep deprivation. It's always one of those things that we're going to get to, isn't it? Poor diet. It's another one. We know how to eat. We know what we should be doing, but are we doing it? And many times we don't do it until we have something like this happen. What if we did it now? What if we started taking care of ourselves now and not wait until something happens? There are some seizure medications that are out there on the market to help control seizure activity, but there is no one best treatment for everyone. It is not a one size fits all. And most of the time, a person has to go through, just like if you have high blood pressure, it's pretty rare that the first one is the one that works. Depression's the same way, where the first one may not be the one that works, so we have to try a different one. Other things that can be done, vagus nerve stimulation surgery to prevent seizures, particularly if there's a mass or fluid in the brain. But to do that, they have to know the exact location where the seizures are beginning. Now, this is interesting, and this is pretty new. A ketogenic diet has been shown to be effective for people with certain types of refractory epilepsy. Keto's all the rage right now. You can find lots of information about that. And some people report success in reducing the number of seizures caused by triggers by adding alternative treatments such as herbal supplements or vitamin supplements, different medications, chiropractic care, and even acupuncture has been shown to help with epilepsy. We have got all of our resources listed here for you. So if you were interested more in any, in fact, that's where some of our videos came from, some of these sites. And then this is resources for caregivers of people with dementia. This is our information again. If we can ever help you with anything here at the West Center, or if you have more questions, and we will have time for questions, I've made sure to leave some time. I am going to put up the slide about the CEs again and let Marty or Jamie hop on and go over that one more time.
I'll be happy to do that. Yes, for those of you that are joining us today, oh, go ahead, Jamie. There's Jamie. I'll let you do it.
Thank you. Yes, so we are able to offer one CE credit for those of you that joined us for social work, nursing, licensed professional counselors, and if you want a certificate of attendance. In the follow-up email you received from Marty, either today or tomorrow, there will be a SurveyMonkey link. Please click that link. We ask everybody to do the program evaluation, but if you want CE credits, you are required to complete the evaluation. It only takes a couple of minutes. And then please allow us 3 to 4 weeks to get those CE credits processed, and then we'll send you your certificate by email. The close date for the evaluation and that link close on the end of the day, September the 21st. Thank you.
Perfect. Also, we have a Google survey that we put out that is for our funding objectives and to collect information and how we're doing on those. And so we ask you also, if you complete the Google survey, it should pop up as you close out of Zoom today. I realize some companies and some of you individuals have pop-up blockers. If it doesn't pop up, you'll also receive that in the follow-up email. And that, as I said, that will go out tomorrow. I've got to commit that as soon as we're done here today. Now, I want to talk about this real quick. Later this month, we're going to be doing our second we're doing every other month. You'll see we have 2 webinars with the West Center. And then the next one is going to be this one is going to be later this month. But I want to point out that this is going to be an hour and a half instead of an hour. Most of the webinars we've been doing in our partnership have been an hour long, but the one on dementia versus depression will be an hour and a half. It will start at the same time, but be 90 minutes. Yeah. So go ahead, Holly. I'm going to turn it over to you guys to address the questions.
Well, and I wanted to mention on the one that we're going to do on dementia versus depression, we really take a deep dive into dementia and what the signs and symptoms are and how to get a diagnosis. And then we're going to do the same thing with depression. We're also going to talk about the link that we now know there is between lifelong untreated depression and then vascular dementia later in life. And there is now a direct link between the two. It's amazing. So we'll talk about depression and then the signs, the symptoms, and how to get an accurate diagnosis. The general public, for the most part, knows just one or two. If you ask somebody to list all the symptoms of dementia, they might be able to give you 2 or 3. There's really about 36 common symptoms. Same thing for depression. You ask a regular person, give me all the symptoms of depression. Well, they're sad. Maybe they're sleeping a lot. 2 or 3. There's about 25 common symptoms. So that's why that one's an hour and a half. All right, let me check chat real quick. For a TBI neuropsych, you're going to be sent to a neuropsych. I actually would start with your primary care physician, start there so that they can go ahead and do a lot of the testing for you. And then they are going to send you to a neurologist. That neurologist will then send you to the neuropsych. But start with your primary care. Will you be posting those as a Facebook event as well? Marty? Yes.
We will. Yes, we will. Both that one and next month's we will get posted on the Facebook.
Perfect. We were told epilepsy is inherited. Everything that I read whenever I was going over the information for this, because we update our slides, is that about 30% of the time that epilepsy is inherited and it is genetic. So a person most definitely can have never had it or have it anywhere in their family, about 70% of the time. But about 30% of the time, there's a genetic factor there. So most definitely. Have you seen Alzheimer's cases more progressive in spina bifida with hydrocephalus? Jamie, can you answer that one?
I was just reading that, and that's pretty specific. I don't know the answer to that, but we could find out and get back to you, Sarah. That
if you will email that question to me, I'll pass it on to, or you can email it to them. Either way, but if you want to email it to one of us, we can get back to you on that.
Sure. And TBI, how's TBI diagnosed? Again, getting to the doctor, they're going to do a complete history. That's where hopefully we've got some good, especially in somebody who did play ball, who was into sports, if they've got a lot of good information, and then they're going to be sent very, very likely to a neurologist, going to the neurologist. Oh yeah, somebody mentioned about competitive figure skaters having concussions also. Yeah, figure skaters and gymnasts, we just don't stop to think about that being, that's not a contact sport. Well, they land on their head an awful lot. So very, very good. I'm reading some of the comments on here. Oh, there was a book recommendation that was put in. Thank you. Oh, my father had TBI concussion at 35 and then early onset Alzheimer's at 57. Yeah, we see that, and we're starting to see it more and more. And we see it so much with veterans.
Oh, veterans.
Electric shock being a cause of TBI. Yes, thank you. Thank you for adding that. Downloading slides. And is Marty using a fake photo? To which I said, absolutely not. That is him.
Now you can see me and the photo together. Can't you see?
And you can see that was just a couple of years ago. Just a couple of years ago. Well, we are right at 3 o'clock. So glad that everybody was here. If anybody does have a question that we did not get to, our emails are on there. Can CTE have an impact on a person's immune system functionalities? I would think that it most definitely could. I don't have anything to back that up, but just from what I know about it, I would absolutely think that it could. I can always research that and get you more information.
Someone
All right.
also-
Thanks, everybody. You'll be getting an email later about this, and we hope to see you on our next one.
Someone also posted that cheerleading is also
Cheerleading.
yes, a big thing. Holly,
Amen.
Jamie, thank you so much. Excellent
Thank you.
presentation.
Yeah.
Thank you all for joining us. We sure appreciate it. Look forward to look for the follow-up email tomorrow. I'm sorry. Y'all have a
And I
great,
apologize about the alarms going off, but I appreciate your patience.
it's just the way it goes.
Thanks, everybody.
It's life. Have a great
Bye-bye.
day. Take care. Bye-bye.